I think it's time for us to get started. We've waited 6 minutes to see who was going to come, and so we've got some news for you that has significant ramifications, sends ripples throughout the medical industry, and that is the Scottish Computed Tomography of the Heart trial reported yesterday that this is the first time that a non-invasive test, coronary computed tomography angiography for coronary artery disease, has demonstrated a benefit, a test benefit, giving a benefit of a 50% decrease in the rate of fatal and non-fatal MIs in hard clinical outcomes through better targeted investigations and treatments in patients presenting with suspected angina due to coronary artery disease. And so here's the control group, which is the red line up here, and then here's and these are in terms of cardiac events, and here's the CTA group. What we mean to say is these patients were patients that had regular stress testing and nuclear test, and these are the patients that had the added value of the CT test. And it's those patients that were selected that had coronary artery disease and went on and had bypass surgery, those patients who had angioplasty, those patients who didn't have any disease at all, and they stopped their statins, and those patients who had juicy plaque, and they put them on statins. And so this is what we've been sort of leading up to in the last 12 years when we started doing coronary CTA in 2004, and it seemed intuitive that if you looked at the artery and there wasn't anything there, that you didn't need to treat the cholesterol. And if you found a lot of stuff there, that was significant. You found a severe blockage there, that was significant. And that seemed so much more important than the SPECT scan. So much more important than the SPECT scan, which had a 40% false positive, 75% false negative. Excuse me, 65% false negative. And so this is a home run. We want to announce this today as a home run. 50%, probably a grand slam. 50% decrease in the rate of fatal and non-fatal MIs. Any comments from the audience?
I have a comment, Dr. Harrison. This is Janet, and one of my dear friends is a CV surgeon, and we've talked about this recently. And even he said at some point the cardiac CTA has become so good and so that at some point will replace many cardiac caths. It's going to take some time to shift that curve, but I think that there's going to be a replacement of that. And then if a cath is needed or warranted, they will then go on and have that done.
It's very good. So that the decrease in caths normal caths went from 60% to 21%. That was the decrease in normal caths. And so right now, normal caths are running 60%, which is a waste of an interventionalist time, also a waste of radiation, and also increased risk. So this is a home run. It's huge. And so for the West Florida division of HCA, we have GE looking at each hospital, what they currently have in CT and MRI equipment, what they would need to upgrade to cardiac, what it would cost, and how you could do it in terms of adding on or replacement, and how you could do it in stages if necessary. So talking about millions and millions of dollars of changing the platform from SPECT scanning to coronary CTA and cardiac MRI. Basically, that's like turning an aircraft carrier. It takes a lot of time, especially if it took 17 years for 60% of doctors to basically give an aspirin when somebody has a heart attack. 17 years for 60% of doctors to give an aspirin. Well, it turns out that the attrition or retirement or disability rate of physicians is 6% per year. So 6 times 17 is 102%. So basically, we had to replace all the doctors. And so by the time all the doctors were replaced, then we had a 60% compliance. That's chilling, a chilling thought.
Dr. Harrison, this is Janet. I had a question about that.
Yes.
What do you think the feedback will be from interventionalists about this new study release that you discussed, as well as, you know, having the opportunity to do the other testing? Do you think that we'll see a shift?
Yeah, the interventionalists are it depends on who they are and where they stand, but the interventionalists are like us, like to be part of a pyramid. The interventionalists are the top of the pyramid, and the bottom of the pyramid, general cardiologists, and then we've got non-invasive cardiologists and then interventionalists. You should have maybe 4 non-invasive cardiologists for every interventionist, and basically we pass up the line the patients that need to have angioplasty. Interventionalists, if you're very busy in a busy interventional laboratory, you don't want to be doing diagnostic casts, you want to be doing intervention. So you're wasting your time. It takes several hours to do a chronic total occlusion. And so if during that hours you're eating up time doing normal casts, which is 15%, well, it's 60% of casts are normal. And so if you're eating up your time doing that, and if it takes 15 minutes to do a normal cath and another 15 minutes to turn over the room, that's a waste of your time. Also, there are some interventionalists that are just out in private practice and aren't part of a pyramid, so they don't have anybody to feed them. So they got to go around doing SPECT scans. You got to get a bunch of SPECT scans, and if you get a bunch of SPECT scans, you're coming out with 40% false positive, 65% false negative. You're taking the wrong people to the cath lab. So the whole system is perverse, and we've got to realign it. So it's going to take some work for realignment. We also have news that for women, a positive cardiac CT was more strongly associated with clinical events than a positive stress test, saying the same thing. The women have always been difficult for us to screen. They have smaller arteries. They may have different symptoms, and so it appears that the bottom line, just as we found with the Scottish study, is the PROMISE study subset analysis of women shows that this is a very good test for women as well. Any comments?
It's a wonderful confirmation of your insight.
Thank you. Well, we've been whacking at this since 2004 and have totally replaced all concepts of doing nuclear cardiology, and so it's nice to see the industry is catching up with our intuition. So we're very happy about that. Let's go on. Mystery case. And so we have today a gentleman to show you, 60-year-old male who's referred April 2009. He works at the airport, screening people for security. He had some first-degree Av block on his EKG, brought his EKG, echo, and wanted us to review and see what's going on. There was no echo abnormality, it was just an EKG abnormality. Patient denied any symptoms. And so this was his EKG, which basically shows his first-degree Av block, and really you can see this EKG is part of his stress test, and so you only have some of the leads, not all the leads, but it looks pretty good on what we see there. And so here's the EKG, first-degree Av block. That's it. I'm not sure why he was referred, but he, you know, maybe no R wave in V1 and 2, but anyway, first-degree Av block. And so we did an echo where we saw the echo that he had done. He had a normal echo. There wasn't anything to be found. We talked about his history, and he didn't have coronary heart disease. We can erase that. His hypertension, hyperlipidemia, and was smoking a little cigarettes now and then, drinking a little wine, and doing some exercise. Family history, his mom had a heart attack to 77, heart failure, and he was on some good drugs there, aspirin and Lipitor. I'm not sure why he was on the Amoxil, and basically on physical examination there were no important findings. And so what were we going to do next? And this was in 2009, and so this is before we developed a workaround from the insurance companies. As you know, the insurance companies drew a line and said don't cross this line, and they put PET, MRI, CT. They put new stuff that was expensive. That's not really a very good idea in terms of not promoting new concepts. But the insurance company's bottom line was money, which is the bottom line. And so they actually created radiology benefits managers. The radiology benefits managers are basically paid to not let stuff cross the line where PET, CT, and MRI are on the other side. And so the radiology benefits managers basically are hired to say no. Every one of them is called, the people they work are basically, usually there's a bunch of group of nurses working from home that have come in and been trained on the algorithm that's on their computer. And then there's some doctors called medical directors who really aren't medical directors, but they like that name. So if you call everybody a medical director, it sounds pretty authoritarian. Those doctors really don't have a lot to do with cardiac imaging. Some may be pediatricians. Some may have been retired for several years. But it doesn't take a lot to be able to say no. So you don't have to have a lot of cognitive power to be able to say no. You can be retired and playing golf 3 days a week and doing this another day. And so works out pretty good. And so we got in touch with one yesterday. NIA is one of the companies. They make 25 cents per member per unit of time. And by saying no, the insurance company makes $3 per member per unit of time. And so that turns out to be pretty good money. There are about five radiology benefits managing companies that make $250 million a year. And you can see they're influencing maybe 31 million lives. And so I had 3 people I was having dinner with one night that were involved in 50 million patient lives, which is amazing. At one table, we had a fifth of the United States. We could be in charge of their insurance and say no. And so it's really cool. $250 million a year for saying no. I would do it for $100 million myself, but that's beside the point. So we got, yesterday we had a phone call with the radiology benefits manager, and we want to do a PET scan. PET scan is now cost the same as a SPECT scan. They cost exactly the same as a SPECT scan at this point. But they still have the old algorithm where they're trying to get rid of them and exclude them because they cost more money. They're on the other side of the line. So they said, no, you got to do a SPECT scan. And I said, well, you know, we got 40% false positive, 65% false negative. And we said, well, this is what the insurance company wants. And I said, well, they're not managing my patient. And, well, the lady said, yeah, they are. And so I said, oh, I guess they are then. And so we're basically being forced to do a SPECT scan when a PET scan costs the same amount and is more sensitive and specific. So it doesn't make any sense. And the entire industry is that way. The bean counters have taken over, and it's a very perverse way of running a medical practice. And so let's move on our patient and see what we can figure out from understanding this guy. So what to do next? And so at this time, we were not able to provide access to CT scanning because we had to ask the insurance companies. And so that was before we had the idea of, hey, you know, let's get a price that the patient can pay out of pocket of $199, and let's take over some of the post-processing that the hospital is having to do for a 10-minute test. So the hospitals were doing a 10-minute test and doing a 45-minute post-processing chore for the technician, making it very expensive, i.e. $3,000. So we said, let's quit doing that, and let's just give me a CD or send it to the cloud, and we'll do our own post-processing. And let's cut the price to $199 special. And so we were able to get that, and so then we didn't have to ask the insurance companies anymore. Oh, the patient said, go ahead and ask them, you know, maybe they'll give us a break, but they don't give us a break, and it doesn't work. And so a patient is willing to pay the same price that he would pay for his own maintenance that we'd pay for maintenance on his car, price of a tire. So the whole total price after overreading everything is a bargain. It's less than $300. So at this time we couldn't do that. They would pay for a calcium score. We said, okay, we'll take the calcium score. So we had a calcium score of 566 whatever that's worth. Well, there was a calcium score of 8 in the main left, 79 in the right, 485 in the LAD. I don't know what good that does me. You know, it tells me the gentleman has coronary artery disease, and that's about it. I can't tell you if he's sitting on a powder keg or if he just has some benign calcification. He's one and done, and it's all burned out, and there's nothing left to happen there. Or if he has just a big, bright, juicy liquid plaque that's about to rupture. I can't tell you anything about that. So we also did a test that Jeff Anderson had made popular. He's at Intermountain in Salt Lake City, and that's the LP-PLA2. Well, what is LP-PLA2? And it's something that triggers some events resulting in endothelial dysfunction, and it's a test for atherosclerosis and plaque accumulation, rupture, and so forth. I can't find that. I ran a bunch of these for a couple months and couldn't find a lot of use for it, but this is basically what was in play at the time, and so I put it in play, and the patient has a normal LP-PLA2. I feel reassured, don't you? And so the next one was, hey, we were doing Lexiscan PET-CT in those days. And so if you have a drop of ejection fraction of 12%, increased RV uptake, that's compatible with main left coronary disease. And so no chest pain, no ischemic changes, normal myocardial perfusion, calcification of the 3 vessels, which we already knew. Ejection fraction went from 48%, which was essentially normal, to 57%, which showed that it increased, significantly. And so it didn't seem like there was a severe problem. So we said, we'll just take care of this guy medically. And so that was our plan. The patient was reassured of his PET-CT, not his specs, PET-CT. Started lisinopril for blood pressure control, diet, exercise, counseling, regular follow-ups. So he developed the usual statin-induced myopathy. Looks like that's about maybe 50%, certainly 40% of people. A PCSK9 study has shown it's 50%. I always thought it was around 40% or greater. So he would switch from one to the other, and sometimes you do better when you get switched over. Blood pressure was well controlled. He had no LVH, which is an endpoint of uncontrolled high blood pressure over a period of time. So it gives us a nice opportunity to look for a marker for somebody who's been hypertensive. He had non-obstructive, mixed, calcified, non-calcified, left common carotid plaque. We take a peek at the carotid, and it's very helpful. Sometimes it's associated with coronary disease. Sometimes it's totally independent. And then a highly sensitive CRP put a patient in the lower quintile of risk from inflammatory markers. So we carried on with the stress echo in 2014. So it went from 2009, 2014, had a stress echo. The echo was normal. And here's a stress test, which shows rather dramatic changes. You can see if you got a normal baseline EKG, that's a nice start. And then if you carry over from a normal baseline EKG to at 4 minutes and 49 seconds into recovery, you can see a lot of changes. You see the patient went 13 minutes and 10 seconds. That's a pretty good exercise time, but you can see we're dragging out recovery forever. Here we are 18 minutes into recovery with still ST segment changes. So dramatic ST changes during at peak exercise, as you see here. And then I don't know why these are all in hodgepodge order, but there's the baseline over here. And here is the peak exercise here. And there's the baseline over there. And there's the maximal recovery. And there's the test in recovery. And you see we just hung out forever with ST changes. And so this has got main left screaming all over it, main left coronary artery disease, in a guy that really didn't have much going on with him. So very positive ST segments changes which occurred at peak exercise hung out for, well, we saw 18 minutes it hung out. Certainly 5 millimeters ST segment, horizontal depression of 15 minutes. Normal rest, no evidence of LVH, because you could get that with LVH. Wall motion abnormality was seen on the resting echo, increased with exertion. So it was an abnormal stress echo, but the guy didn't have any chest pain with 13 minutes and 10 seconds. So we didn't do anything. What to do next? We did coronary CT. So let's look at his coronary CT. Hang on, we'll get it up. So the purpose of this conference is to get you up to speed on multimodality imaging, especially CT and MRI. And as you see from what we discussed, CT is the king. CT is the king who hasn't found his place on the throne yet. And so we can look at these coronaries and you can see there's some stuff in there. You can see just from the outside there's been significant changes and positive remodeling in the vessel, where it gets bigger over here and then smaller over there and then bigger over here and bigger over there. And so definitely it's got lots of ripples, and so there's been an atherosclerotic process that's been going on in this patient. Here you can see a little calcific lump that's peeking out of the vessel where it's positive remodeling. There's another little ripple of positive remodeling. Here's positive remodeling over here. And so these vessels, basically, if you did time-lapse photography, you'd see they were undergoing a lot of changes all the time. This whole area here appears to be ectatic and calcified. So let's go over here and take a look at the axial images. And there's our axial images. See the aorta, left atrium, descending aorta, and just big hunks of calcification. Here's a big hunk in the main left coronary. Here's a big hunk at the bifurcation. There's the circumflex coming off. There's the LAD. There's a big hunk of calcium in the LAD. Another big hunk. More hunks. And so this is all indicative of an inflammatory process that took place. And hopefully this is the end stage of it. But you have to look and see if there's vulnerable plaque in here. And so what we're seeing is burned out plaque, the carcasses of some blisters that occurred inside the artery. It may have been some recurrent ruptures, but not an occlusion. And then fibrous changes, and then after that, calcific changes with remodeling the vessel and pushing out of the vessel to keep the channel open. You can see all that in the right coronary artery, even almost out to the bifurcation here. And so let's go inside these arteries and take a quicker look. But everything looks pretty good that we're looking at here. Got some nice internal memories for the future if we need those. And so let's go take a look and see what things look like. Hang on here. And so I like to use the 3D model as my guide as we look at the vessels. So we're going to take a look at the left anterior descending first. And here she is. Make that bigger. And we'll line it up better. Move this over here a little bit. And calcific, calcific, calcific. Really can't see inside at those places. Look how much positive remodeling it is. This whole big hunk is extending on both sides away from the artery. The artery is really quite small. These arteries are 3 millimeter. That's normal size. 4 millimeter, 3.5. Okay, and then we can actually do a cross section over here. We can make these things bigger. So this is basically post-processing that we're doing, and this is what we laid off from the hospital. And we said, we'll do the post-processing. That'll cut 45 minutes off the test, and you can charge $199 for the test. And so that made a lot of sense. So that's how we got away from the insurance companies. And so now we can go up and down the vessel. And so there's a big piece of calcium. There's a piece of calcium there that you might not even be, it's not too dense, but we'll see if we can see through it, because sometimes you can't see through it. It looks like there is a channel going through here, and then we get to this point and we can't see through it, so it totally opacifies the vessel. And then we're down here, and we can't see the channel coming along. We can't see the channel down here, and then we can see the channel again, and then we can't see the channel. And so a lot of this is called blooming artifact. And so when we get our next iteration of computer post-processing to get rid of noise, we can get rid of some of the blooming artifact and be able to see around it. So we're looking forward to that if we can get the bean counters to buy it for us. And so here we go, looking at this. And so let's take a look at some more vessels. So let's go to a ramus, and here's our ramus. And it's a small vessel. I'm not sure if this gentleman had nitroglycerin or not. Supposed to get nitroglycerin to try to dilate them up. And so we're moving our way through the circumflex. And now we're going to come over here and pick up the right. Right looks like a pretty big vessel. This is a vein going along here. That's the interventricular sulcus. And so here we're going to click on here and see if we can get the right up. And here comes the right a little bit. We can make it come along here by guiding it. I'll get my pencil and move up here, and we'll guide the right. And so here we go along the right. Just sort of make our way up here slowly, and a little more tedious. You can see why post-processing might take 45 minutes, because you got to make little corrections for the computer. And so there we go. We've got the right in its entirety. We've got it upside down, but that's okay. There we go. This is the origin of the right. And here it comes down this way. And we can see, again, pieces of calcium. Can't say I see a lot of inflammatory reaction. Can't say I see a lot of plaque that's dangerous or risky at this point. And so it looks like just had a lot of stuff happen once upon a time. And we're sort of where we are now is stable coronary artery disease. So we said, hey, let's treat him medically and see how he does. And so we found least moderate distal left main disease, calcification, very dense, couldn't see inside, couldn't judge if there's significant stenosis, and then mild disease in the LAD circumflex and right coronary arteries. There was some atherosclerosis in the aorta, small patent foramen ovale, left to right shunting, it didn't mean anything, no significance. So we're pretty happy with that. So we said, hey, we'll just treat you medically. You can go back out there to the airport and screen people in security, and we'll just follow up on you and see how you're doing. We did do an MRI at some point, and we said, you know, maybe we need more objective information. We're always concerned when there's main left calcification. We're always concerned that there's something we're missing. And so let's take a look at the MRI here. So we've got an MRI. And again, the whole idea of this conference is to get you on board with advanced cardiac imaging as we add MRI and CT to our repertoire. And so here's the aorta. Here's the descending aorta. This is the ascending aorta. This is anterior. This is posterior. And there's the origin of the right coronary artery right up there. It's about between 11 and 12 o'clock. Here's the origin of the main left coronary artery down here. It looks like at about 2 o'clock. Here's the left anterior descending. Left atrium. Left ventricle. Looks nice. I don't see any thinning. I don't see any scar. Here's the right coronary artery again over there, running in the AV sulcus. And right atrium, right ventricle. The PDA would, the probe patent foramen ovale would be somewhere in this area, PFO. So let's take a look at some other images as we go along here. And this is a non-contrast study. Look how pretty. It's almost like you got contrast. Looks like contrast. Looks like a coronary. Looks like a left ventriculogram with angiography. And so you see the mitral valve looks very competent. Left ventricle looks very competent. Nice contractility symmetrically. No enlargement in any chambers. And we can just flip them over I'll show you these images. There's the aortic valve opening very nicely. Mitral valve, so you get 2 valves you can see here. That's pretty good. This is a 4-chamber view. Here's the tricuspid. Here's the mitral. You can get any view you want. With echo, you have 4 standard views, 4 standard windows. If you don't have the window, you can't see it. This one, we've got infinite windows, as many windows as we want. That's what makes it so nice. It's not a portable unit. It's a big old machine, but you have these big old machines in every hospital, and an upgrade is pretty simple. That's not going to do. Let's turn that off. And so this is some more imaging at apex, mid, and base, trying to look for edema. So that's called T1 imaging. And here is the right ventricular outflow tract. And so that's the pulmonary valve right there. And that looks very pretty. Left ventricle, aortic valve. That's really nice for the left ventricular outflow tract. This is all looking very nice, this gentleman. But let's put some contrast in there and see what it looks like. Well, this is not contrast. This is phase. Phase is the same thing you do when you do a Doppler. This is contrast, so let's see what happens with this one. When you put contrast in, you really like to sort of dim things down a little bit because it gets pretty bright. And so you want to see the effect. And the contrast comes in initially. If there's some areas that aren't filling with contrast, and there are areas that aren't filling with contrast in several areas, in several places, that initially there's a black zone in various places around here. Black here, black over there, black over there. And so that's not quite right. We could actually color code this for you, and maybe we'll do that next time. We have some software for that. Makes it easier to perceive. You have it color coded. And so it looks like multi-vessel coronary artery disease when you look at that. This is looking for scar. And so this is supposed to be very densely black all the way around, which it is. This is called late gadolinium enhancement, and there is no scar. And so there's never been a cardiac event, no scar all the way around here. Any way we look at it, and no scar in there at all either. And we had some perfusion defects. So let's go on. So hypoperfusion in the endocardium, the lateral inferior septal region suggestive of ischemia in the right coronary and circumflex territories. Amazing. In this guy, we didn't think there was much wrong with it. Ejection fraction 46%, looked mildly decreased, could have been some PVCs, no scar, right atrium was enlarged. I think we overread the right atrium and left atrium on this study. Well, it's been a couple years, so we said let's do another stress test. Actually, it had been since 2013, and so 14. So we said let's do a stress test. It's been 2 years. You know, here's a guy who's asymptomatic. I'm still worried about him. Why am I worried about him? Well, now I got a positive MRI. I have a positive stress test. I had prolonged hangout, no symptoms. And so here we go again. And let's see what things are like today. Well, he dropped his exercise from 13:10 to 11:10. So he's two minutes down in just a couple years in his exercise. No chest pain. Some people just don't perceive chest pain. But look at the ST segment changes. Normal EKG at rest, and look at all this hangout that's occurring. It just keeps hanging out there. And so at 17 minutes, it was still abnormal. We ended the test. We got tired of sitting around watching the hockey sticks of the ST changes. We have stress echo, and we're going to skip the stress echo, but the stress echo had some wall motion abnormality in the inferior wall that seemed to get worse, and it looked like several areas, just like the MRI. There were several wall motion areas. This is basically what we're looking at is the peak strain. And so we can see the strain has some abnormalities here and some abnormalities all the way around. Normal peak strain is usually like -21, and we've even got some plus numbers here. So something going on with this heart. And so here's a cardiac cath. We finally said we got to break down and send this guy to cath. You know, he has a main left lesion. He's had one all along. We've been sitting on it. But I don't know if I can continue to do that, especially with those ST changes and decreasing exercise capacity.
Mm-hmm. Wow.
So we're going to show you that basically, I don't like bypass surgery, and you saw the Cath images, and it looks like we don't have a choice on this one. Maximal medical therapy we did for 7 years. Angioplasty we do in older people, and so, but bypass surgery is a crapshoot, and so we never know what's going to happen. Patient comes out and has a stroke, whatever, and so it's uncontrolled. Ostial main left needs to be distinguished from mid-main left, from distal main left, from tubular main left. And let's get our second case, a 62-year-old retired male family history of significant coronary artery disease. His identical twin brother had severe coronary artery disease and died from bypass surgery on the table. They couldn't get him off the pump. And so this guy came to see me, and he had some chest pain. And I said, well, you've got the same thing your brother had. What did your brother have? And he said, well, my brother had main left disease and LAD disease. Well, I said, you probably got main left disease and LAD disease. And basically, he has a lot of other things wrong with him. So did his brother. And his physical exam was normal. And he did have a stress test, and he didn't have any chest pain. He had no ischemic changes during the stress test. It's PVCs and PACs. We decided to check his coronary CTA. So hang on, please. So here we go with his CT, and we'll move along quickly on this one. But what I want to show you, usually we go straight to the main left and LAD, so let's go to that one and see what we can find. And so let's make this bit a little bit bigger so we can see it, and make that bigger. You can see that. And voila, let's make this bigger. And let's get some more cross sections here. And so we're doing the post-processing that we took over from the hospital to lower the price. We're going to color code this. And you can see that here is a very nice plaque. It's got, actually that's contrast inside. The plaque is ulcerated. That's not calcium. It's the same Hounsfield units as the contrast. And so that's, here's some also some non-calcified, non-fibrous necrotic core, big hunk of it there. And so this is a very dangerous plaque. And this plaque extends into the main left. I can take this off and show you. It's extending into the main, this is the main left artery here. So it's ulcerated, it's ugly, it's narrowed, it's extending in the main left. And then this is a ramus with a significant narrowing, and this is the circumflex with the significant narrowing. So that looks very bad. It's in this trifurcation that everything looks terrible. Let's go to the right and see what the right looked like. And right, certainly proximally the right's not bad. Check it out more distally, but certainly proximally it's not bad. Let's go down here and take a look at it. And you can't see it very well. There may be some motion artifact, so we can't see that very well. Let's take this off. From the outside, there it is. Looks like it narrows down quite a bit. Looks like there's some misregistration in here. But the right we weren't as concerned about. And so this gentleman has classic main left coronary artery disease and has the same thing that his brother has. You'll find that with twins. And that's why we use twins for so many studies that we do. And so the calcium score was very deceiving. Here's a calcium score. Calcium score is very deceiving. Here's a calcium score at 9. A very complex, non-calcified plaque in the mid and distal LAD. It's got an ulcer in it, severe LAD, severe circumflex. Everyone say that this gentleman needs bypass surgery, of course. But of course not. I mean, basically, his brother died on the table, and so he's not going to go have bypass surgery. There's 2 reversible defects on the PET scan, correspond to the diagonal to the right. PET scan shows 74% ejection fraction increasing 84% with percentin. A drop in ejection fraction of 12%, increased right ventricular uptake, is significant for main left coronary disease. He doesn't have that, so perhaps that main left narrowing is not severe enough. There's nobody, 10 out of 10 cardiologists would elect for this guy to go to bypass surgery, but he's not going. And so we said, we'll treat you medically, give you regular follow-up, keep an eye on this. And so we're breaking all the rules, but his brother died on the table, he's not going to do it. And so we do another PET scan in 2009, and it looks pretty good. We've got perfusion defect now. It's 25% of the left ventricle when he exercises. basically, but there's no scar, really no scar. Even though we get these little dingy things on our PET scan, there's no scar. Here's where his ejection fraction dropped, but then the next year went up, so see that as you want. And so he's had other problems. He's had some pneumonia. He's had gallbladder disease, and we've taken care of him. His creatinine's gone up some. He's been on drugs for HIV, and here we are following up on him. He said, I feel very fatigued. Is it my heart? And we said, well, I don't know, but let's put you on the treadmill and we'll see. And we did put him on the treadmill, and you can see his EKG was okay. I only have this one lead, but there's some early repolarization. And then you can see that during exercise he did get some changes, but not like the other gentleman. And you can see that he didn't go very long on the treadmill, 7 minutes and 23 seconds. But that's pretty good for him because he's a puny little guy and has a lot of other medical problems. And so we concluded after this that his fatigue was due to his other medical problems and not due to his coronary artery disease. And so we were happy with that. And plan, well, here we are, 7 years with main left coronary artery disease, same that his brother had and went to surgery and died. This guy got 7 years more than his brother did. So, and the guy you saw before got 7 years also, basically of managed medical care, and both of them did what they wanted to do. And so the answer isn't always immediate bypass surgery. It looks like you can care for people with 50% main lefts, and they seem to do quite well on medical management. Certainly these that we've showed you. There's a third case who had a 3rd degree AV block and got a pacemaker, who had the classic nuclear stress test with, as you know, 65% false negative. He had no ischemia in his nuclear stress test. He's got shortness of breath and fatigue. He was being checked out because he had pacer, and people want to know, is there anything else wrong with him because he's having chest pain. And so now nothing else wrong with him except on 6/15 he had a non-STEMI, which was 6 months later after he actually this is must be wrong timing on this. This is 12/15 and that's 6/15, so little discrepancy on this. I think this was at 14 probably. So we take a look at this guy's vessels and see what we can learn from this one. We'll start with here. Now, this is a distal main left again. We're not dealing with osteal main left disease because you're going to learn that osteal main left disease is more dangerous in the cath lab because you jam a catheter in there and then you inject toxic material that doesn't carry oxygen. But let's look at this, and there is some narrowing here in the main left. There's distal main left narrowing, and then there's proximal sort of LAD, proximal circumflex. A lot of calcification. That doesn't look severe. That looks like another one of those 50%ers if we were going to stop it and measure it. There we go. I don't know if I have a measuring tool that's available to me here. I don't see one. Options. Let's go over here. No, I don't have a measuring tool. But it looks to me like if you measure this to this and this to this, that would be about a 50%. And so, of course, it's in the eye of the beholder. If you're an interventionalist, you're going to appreciate that a lot more. Of course, nobody's going to do an FFR, because if you do an FFR, you might not be able to do a stent. You might do an IVUS, because then you can say it looks bad. So if you don't want to bypass it, you do an FFR. If you want to bypass it, you do an IVUS. Or you just don't do anything and just look at it and say, hey, it looks bad. As you know, 50% of patients of arteries that get stented don't need stents by FFR. Here's your LV-gram, normal LV, looks great. Okay, well, why do you go in and do an LV-gram if you got an echo that shows a normal LV? Well, it turns out the procedure pays more if you do an LV-gram, and actually it pays more for the LV-gram than it does for the coronaries, which is kind of perverse, doesn't make any sense. So you got to go across the valve, inject a little dye by hand, and then sort of a token angiogram, and then you get paid for the left heart cath, which pays more than coronary angiography. So we're dictated by Medicare, insurance agencies. All these people tell us how to do these cases in terms of their incentive of paying us. And then we're trying to get in the right coronary there, and just sort of being jolted around a little bit. Whoops. Looks like we're getting an angioplasty done. I don't think we ever saw the right coronary. No, never saw the right coronary. But nevertheless, moving right along. Who cares about the right, right? Let's go take a look at the money shot. And here we go. This is a high-risk procedure. We're coiled in a little aneurysmal area there. Main left, unprotected disease. Getting a stent is considered a high-risk procedure. That's what we're doing. So cross your fingers on this one. We've got wires everywhere. We got stents being deployed. There's this. We got a stent being deployed in the LAD that's extending into the main left, and then another stent proximally in circumflex, sort of kissing stents. And so that's what's happening here. Looks like a long procedure, lots of balloons. Distal main artery is being ballooned, but really not being stented. The stent actually goes into from the LAD, looks like it goes into the distal main. Looks like the main was angioplastied. And that stent is extending out a little bit into the main left. So I don't know what the future is for this one, because it's almost like the main left got angioplastied but not stented. The stent just pokes out just a little bit. So here's the results of cosmetically. So let's go on. And basically had CTA, which showed just calcium all over the place, and the CTA wasn't of much help. He had this angioplasty after the cardiac cath, angioplasty of all these vessels, and I don't know what these numbers are. I can't tell you in terms of 70%, 90%, 80%. That's in the eye of the beholder. He had the angioplasty, and then he started getting symptoms again, and so he had a coronary CT that had a lot of calcification, and then another cardiac cath. Let's look at the other cardiac cath. So here's the repeat cardiac cath within, I guess, 6 months. Here's the stent going into the circumflex, stent going to the LAD, 2 stents, the stent extending maybe just into the opening of the main left. This is a catheter that fell across into the LV and said, hey, we got to go to cross anyway because insurance company will pay for it, getting crossed. And then if you inject some dye, insurance company will pay for that too, so we got to do that too. So it's just sort of a token because we have all the information from the echo and don't even need to do any of that. And then trying to get the right coronary artery again with this time it looks like an Amplatz catheter. And so let's see what happens this time, if we get the right or not. And whoopee, we got the right this time. So the person gained from looking at the previous person's cath and realized you need a different catheter, and so it looks like an Amplatz catheter was the catheter of choice to get the right. Couldn't get the right last time with universal catheter. This is sort of a universal catheter again, injecting the the main left, and this time you can see there's severe disease now, because he took a main left that was a maybe 50% lesion, angioplasted it, and have a stent that's extending out from the LAD into the main left, which is no, and so messy looking thing. And so now we got real trouble. Now we got trouble, real trouble. This is real trouble. And so everything else looks the same. So in conclusion, this gentleman had a stented segment of the main left with now, after bare angioplasty on some of it and the stent extending into it from the LAD, now we had a big problem in the main left that we didn't have before. Now we got some osteo-LAD problem, and we got all this stuff scattered around, which was scattered around before. And we got the first good look at the right that has a 80% lesion. So this, obviously, this guy's going to have surgery. And he's stable, but he has a lot of problems. He has some cirrhosis of the liver, and he's got some decreased platelets, and he's you got to be able to do the surgery very successfully, get him out of surgery, get him. He's on Plavix, so he's going to have to take a week to get off his Plavix, or at least a few days. And so in the hospital post-procedure, took him off his Plavix. A week later, he had some bypass surgery and had a bleed and got basically a bunch of drugs and shut down his kidneys, and the bleed wasn't detected for 2 days, and basically the vasopressors shut down his kidneys and shut down his liver, and he got a septic shock, and he's gone. And so we just wanted to show you main left disease and let you understand that cardiac CT can play a role in that. Medical management can play a role in main left disease. Here's a gentleman that we also sent to surgery, and he has done fine. He's not so complicated. He didn't have cirrhosis. He didn't have low platelets. He didn't have restenosis from angioplasty. This guy had a main left for at least 7 years. It's probably a 50%. I've had 50%. I've managed conservatively for 7 years easily. Gentleman before, this last one, the second one didn't have surgery at all. He didn't have surgery at all because his twin brother died of surgery. And then the first one basically had surgery after 7 years, and with progressive disease, with still no symptoms. And we felt compelled, because of the ST changes and the decrease in exercise capacity, we felt compelled to send him to surgery, which he's been successful. So we have 1 7-year follow-up, finally did surgery. Second case, 7-year follow-up, still no surgery because his brother died. And then the third case, stumbled across a 50% main left, stented it, stent restenosis and complication, very complicated guy, went to surgery and died from surgery. So shows you that it's a very difficult disease. It can be managed medically. The surgery can be, you have one shot at the surgery. It could be a crapshoot. And we had a lady that had a thyroid disease and had an ectopic thyroid next to her main left and got radioactive iodine and basically got a main left stenosis and had surgery successful. And when they pulled out her subclavian catheter, it was through the artery and the vein, and she bled into her chest and died. And so the surgery becomes very difficult because you don't know what's going to happen. It's the uncontrollable stuff. And so medical management seems to be controllable. We have resuscitated people who have sudden cardiac death from main left and have been successfully resuscitated. People with main left have gone on to have gallbladder surgery and other things if they're only 50%. And so going back to our other points, we basically want to celebrate with you 50% decline in the rate of fatal and non-fatal MIs seen for the first time with a test, non-invasive test, which is cardiac CT. So thank you very much for coming today. Time's up, so we'll talk again soon. Bye-bye. And goodbye, Robert, Christine, Teresa, Sharon